Okay, well, good day, everyone, and welcome to Pediatric Teaching today. I thought it was timely to talk about diphtheria because it's not something we've talked about before, and it's not something we've had paid much attention to. I think in regard all the vaccine-preventable diseases, we've been focusing, of course, a lot on things that we recognise, on measles and polio and other vaccine-preventable diseases, pertussis, but there's been, I think, very little discussion about diphtheria. But like many of the vaccine-preventable diseases, there's certainly been a resurgence of diphtheria in many countries around the world, including countries that are very close to the Pacific and including in Australia. And I wanted to talk about diphtheria so we all have a good understanding of what it is. And so perhaps we can recognise it, because I suspect that there are cases that occur and we may not recognise it because it's sometimes a bit hard to distinguish from other causes of similar presentations. But we'll just go through diphtheria, the clinical presentations, the microbiology, the treatment for a case of diphtheria, and prevention. I'll talk a bit about the pathophysiology as well. So diphtheria is a very old disease, as you know, and I think for most people, they would not have seen a case. I've only seen one case in PNG. That was many years ago, but really, it has been an unrecognised disease up until now. Certainly in 19th century Europe and England, diphtheria was a very common cause of child deaths. This is a painting of a child called the sick child, but this child had diphtheria. You can see there's some characteristic features of this. See how swollen this boy's face is. He's got a high fever and he looks toxic, but his face is swollen. He's got a sort of bull neck, which is one of the characteristics of diphtheria. I just show this because it is again, a very old disease. But it's making a resurgence. Diphtheria is caused by Corynebacterium diphtheriae, which is a gram-positive rod. So it looks like this on gram stain. We know we've got gram-positive rods, gram-negative rods, gram-positive cocci, and gram-negative cocci, and there are some bacteria that are pathogens within each of those four different groups. Well, Corynebacterium diphtheriae is a gram-positive rod, and there are some other gram-positive rods like Clostridium, for example. They're gram-positive rods, but Corynebacterium diphtheriae are gram-positive rods. And that's what it looks like if you do a throat swab in a patient who's got diphtheria under the gram stain and the microscope. That's what it looks like. Usually, it's this bug called Corynebacterium diphtheriae, or sometimes it's Corynebacterium ulcerans. That's another species of Corynebacterium that can cause diphtheria, but mostly it's the diphtheriae bacteria. It usually, to begin with, infects the respiratory centre and usually infects the nose. So children can be colonised with Corynebacterium diphtheriae without having any clinical features, but it infects the nose and the throat and the airways, usually the upper part of the respiratory system. It also can affect the skin, and that's usually a different disease. And there are different aspects to it, both immunologically and also the clinical features. I'll show you some pictures of cutaneous skin diphtheria, and that also can be quite hard to identify and separate out from other types of skin ulcerations. But the cases that have been seen mostly, certainly in Australia, have been respiratory diphtheria, mostly. There is some children that have asymptomatic carriage of diphtheria, and they can, or even adults, and they can be obviously a source of spread within a family and a household. Diphtheria also, it's predominantly a toxin-mediated disease. It's not so much that the bacteria get into the bloodstream and circulate and cause severe systemic illness, where the bacteria produce a protein toxin and a diphtheria toxin, toxoid, and that can cause systemic disease. And so some children, in fact, in many countries, most children who have a very severe form of diphtheria have toxin-mediated myocarditis, so they can look like they've got a cardiomyopathy or severe, sometimes severe cardiac arrhythmias, and sometimes they can look like acute flaccid paralysis. They can have an AFP-like illness because of the toxin effect on the nerves. So diphtheria can present in many ways: respiratory problems, skin ulceration, myocarditis or heart failure or shock, septic shock, or acute flaccid paralysis. They're the different manifestations. As I said, Australia is currently experiencing the biggest outbreak of diphtheria in many decades, and only just in the last 18 months, the first cases reported in over 30 years. So far, there's been over 200 cases. I think there's about up to 240 cases in mostly in the Northern Territory, but also in Western Australia and a smaller number in far north Queensland. So it's not impossible that there could be cases that there could be transmission of diphtheria to countries in the region. And it's also quite possible that diphtheria is also endemic in Papua New Guinea and other Pacific Island nations, but it's not as recognised as what it is where you've got more complex microbiology. Mostly the children affected in the Northern Territory have been Aboriginal and Torres Strait Islander populations, but many populations that live in the rest of Oceania live in similar living conditions to children from Aboriginal and Torres Strait Islander populations. So I think the risk factors remain, rather similar actually. There's also recent outbreaks in other countries around the region. So in Indonesia, a large outbreak in Jakarta with 283 patients affected, and their case fatality rate was not too bad. It was 3.5%, but many of the deaths were associated with myocarditis. And they did these authors did a study looking at the risk factors for death, and I mean, not surprisingly, if you hadn't been immunised, then much more likely to die. Almost all immunised children are protected quite well against diphtheria. Those with stridor or a bull neck, that characteristic swelling of the neck and lower face that I showed you in that painting, a marked increase in white cell count, a very low platelet count. They were the risk factors for death they found. But I guess what it tells you is that there's diphtheria is very close by in Australia, in Indonesia. There was another report of cases in Brazil recently, just 27 cases, but they identified many atypical presentations. They showed that some children could present with acute flaccid paralysis, lower limb paralysis, and some children could present with cervical lymphadenopathy, and without that pseudomembrane, the grey membrane that I'll speak to you about. So I think there's a wide range of presentations, even from just severe pharyngitis, tonsillitis, to more severe airway obstruction. In Laos, not far away, large outbreaks of diphtheria occurred. It's a while ago now, over 10 years, but they had a very high case fatality rate, 19%. And then much larger outbreaks that have been reported in both Nigeria, other African countries, and in Yemen, many thousands of cases and many hundreds of deaths. So diphtheria is around. It's a bit resurgent since immunisation rates have declined a bit since the COVID pandemic. And I think we should be prepared to see some cases. It's the pathogenesis. The pathogenesis is what is the pathology that causes diphtheria. Pathogenesis, I think, is interesting in it, and it's primarily, again, a toxin-mediated disease. So the bacteria produces a protein toxin, and the diphtheria toxin was one of the first toxins that were isolated well over 100 years ago, nearly 150 years ago. The bacteria was first cultured, and then soon after that, the toxin was identified. And it was there's not all Corynebacterium Diphtheria produce toxin, but most of them do these days. And the toxin's produced by a particular toxin gene that the bacteria has that produces produces the protein toxin. The immunization against diphtheria is really immunization against the toxin. It's not so much against the bacteria, but it's against the toxin. So it's an antitoxin. The diphtheria immunization produces antibodies to the toxin, and the toxin is quite a severe toxin. It blocks protein synthesis. So that the toxin, when it affects the mucosa of cells or other cells, it stops the cells producing protein and leads to protein destruction. And so that's the result of the necrotic mucosa of the pharynx, and that leads to that. I'll show you the grey membrane that appears on the pharynx. A little bit different to children who've got tonsillitis from say, group A streptococcus. That doesn't usually cause such necrotic mucosa, and so it's the grey membrane that seems to be the characteristic feature of diphtheria. Just the clinical manifestations are important because it can present a bit like many other diseases. It can present just like pharyngitis, sore throat, tonsillitis, croup because it causes swelling of the airway and obstruction. It can look a bit like epiglottitis, and again, an old disease where the epiglottis is infected and very swollen. It can look like that because the children have a stridor and a snore, and they look very toxic. They often look quite toxic. It can look like a quinsy or a peritonsillar abscess. So in the differential diagnosis of upper airway obstruction, things like croup and tonsillitis and peritonsillar abscess, epiglottitis, they all are part of the differential diagnosis of diphtheria. On examination in children who've got moderately advanced disease, where they've got mucosal destruction, they have a thick grey membrane that coats the pharynx. Although if you see them early, they often just have pharyngeal erythema, just like a child who's got tonsillitis or pharyngitis, and it's not always that evident. But if they've got airway obstruction, then usually you see the grey pharyngeal membrane. It can also look a bit like mumps sometimes because of the bull neck. When you've got mumps, you've got parotitis and quite a swollen neck and jaw, or it can look like lymphadenitis. Lymphadenitis can produce just big lymph nodes in the neck and produce that swelling. So when you see a child who's got upper airway obstruction, I mean, diphtheria is not the first thing you think about, but it should be in your differential diagnosis, especially if you've got a child who's got a pus or a grey pharyngeal membrane. It can also present with skin manifestations, but usually children don't have both. Usually children don't have both respiratory and skin manifestations, and it's usually one or the other. I'll show you some pictures of the skin manifestations. This is what the pharyngeal membrane looked like. You can see in this boy, he's got quite a swollen neck, and that's a lot of that is lymphadenitis, lymphadenopathy related to the diphtheria. And this is in his throat. You see the back of his throat. You can see this grey purulent membrane on the back of his throat. That's what it looks like. And sometimes it's darker than that. It's even more grey. It can be black. But again, that's in a more advanced cases. But so look for lymphadenitis, quite tender lymphadenitis, facial swelling, especially of the lower face, neck swelling, and pharyngeal erythema, and this grey membrane at the back of the throat. With stridor or snore, sometimes these children have a snore or a stridor, it's like as if they have a obstructive sleep apnea and they're snoring. That's a feature. So that's the respiratory manifestations. And again, it's toxin mediated. The toxin, the bacteria affects the throat, produces toxin. The toxin causes the destruction of the mucosa of the retropharynx, leads to the grey membrane on the throat, and children from that get airway obstruction. And that's in the cases that have been seen most recently in the Northern Territory and in Jakarta. The most severe cases and the only deaths that have occurred in children that have got those manifestations. And again, sometimes the toxin gets into the bloodstream and can cause myocarditis. Yeah. This is the skin manifestations, and they're, if you've been following these lectures, we had a lecture a little while ago, 5 or 6 weeks ago, on tropical skin infections, and they look a little bit the same as some of the tropical skin infections that we talked about before, including mycobacterial infections like Mycobacterium ulcerans. The manifestations of cutaneous diphtheria look a bit like Mycobacterium ulcerans, or even, you might remember we talked about another type of tropical skin infection called Mycobacterium marinum, which arises from infected tropical seawater, usually where there's a lot of fish that are swimming, and Mycobacterium marinum colonizes warm tropical water and can lead to a skin infection that looks like this. There's a number of other bacterial infections that can look like cutaneous diphtheria, but this is one of them. It's usually initially starts as an ulcer, often what we call a punched out ulcer, where there's an Isabella, do you mind muting your device, if you could, please? Thanks. It begins as begins as an ulcer, which becomes a punched out ulcer. You can see the sort of the raised appearance around the ulcer, and again, it looks a little bit like Mycobacterium ulcerans. Sometimes you get multiple ulcers, as you can see. There's sometimes multiple, and sometimes it's just a solitary ulcer. Yours is another differential diagnosis of this sort of ulcer. Yours, Mycobacterium marinum, Mycobacterium ulcerans. Mostly the hands and the feet are affected, but that's not dissimilar to yours, and it's not dissimilar to Mycobacterium ulcerans. And with time, the ulcer deepens, and you get a sort of brown-grey membrane, a bit like the membrane at the back of the throat, forming at the base of the ulcer, almost like a necrotic membrane forming. The surrounding skin is blue, and some is pink, but often turns purple in colour. It can be swollen and heaped up, and many of the lymph nodes, just like in the throat where the cervical lymph nodes are enlarged, many of the draining lymph nodes of any ulcer are quite enlarged. And I guess just like Mycobacterium ulcerans, the Buruli ulcer, and just like Mycobacterium marinum, and yours, it can follow insect bites or scabies or other dermatitis. So you can get, if you've got Corynebacterium diphtheriae on the skin, if you get a scratch or a bite from an insect, then the bacteria can infect the skin breach, the breach in the skin, and can lead to an infected ulcer there. The differential diagnosis, as I said, first of all, think about yours because it's very common. Think about the Buruli ulcer. That can look rather similar. Think about other mycobacterium, this Mycobacterium marinum, so-called fish tank granuloma, but a tropical sea ulcer is a better name. We usually, if we see an ulcer like that, we treat for Staph aureus because staph can lead to an ulcer like that. And then fungal ulcers, we've seen a couple of fungal infections that look a bit like this, Aspergillus, and particularly a fungal infection called Nocardia asteroides. It's not uncommon, and it leads to a sort of necrotic ulcer like that. And then, so they're all the infections, fungal, bacterial, and then occasionally there's a, immune-related tropical ulcer that looks a bit like the cutaneous diphtheria. One's called pyoderma gangrenosum. They look just like heaped up ulcers. And granuloma annulare, they're immunologically based tropical ulcers. But think about yours. Think about Buruli ulcer, because they're more common in PNG. Think about Mycobacterium marinum, because I think it's quite common, and staph, of course, as well. To make the distinction, you really need to get a swab from the wound. And if you swab the wound, you see the same as what I showed you in that microscope slide before, those gram-positive rods, gram-positive bacilli or gram-positive rods on gram stain of the swab. If you saw gram-positive rods on the swab, you'd think about cutaneous diphtheria. Fortunately, if a child's got cutaneous diphtheria, they rarely get respiratory diphtheria. They're usually quite different. And the reason they're different is because children who've got cutaneous diphtheria, they mount a good immune response. Even if they're unvaccinated, they mount quite a quick immune response. Whereas children who've got respiratory diphtheria, they usually get sick so quickly that they don't have time to mount a good immune response. And that's why they get sicker and sicker. It takes some time to mount a good immune response. And if you've got cutaneous diphtheria, then it's usually a sort of chronic ulcer that you've got for weeks. And then a good immune response can be mounted. So it's unlikely that the child will get respiratory complications. It's the opposite the other way around. So the immunology of diphtheria is interesting. Just on this, cutaneous diphtheria leads to a rapid immune response. Respiratory, so in fact, cutaneous diphtheria is rarely fatal. It causes a chronic ulcer or chronic ulcers, and it but rarely is fatal. Whereas respiratory diphtheria, has a slow developing immune response, and usually the patients get much sicker so quickly they don't have time to develop that protective immune response. And so if a child's had respiratory diphtheria, even after if they recover, even after that, they still need to be immunized because they're not immune protected against diphtheria. They need to still be immunized. The bacteria, as I said, rarely produces bacteremia. You don't often grow it in blood cultures. The diagnosis is clinical based on the appearance of the throat and based on the clinical picture, or based on a swab of a wound or a swab of the throat. But you don't grow it in blood cultures, and that's because it's most of the disease is local toxin production of that protein toxin that leads to the mucosal destruction or destruction of the skin. Some children or adults who have cutaneous diphtheria can be a reservoir of infection to other people. And sometimes if you've got an index case in a family that's got cutaneous diphtheria, they can spread it to a child who then gets respiratory diphtheria. So one can spread to the other. There are some people who have diphtheria in their throat and can also spread it. But the spread within a family is quite high. So if you've got a case of diphtheria, you also need to prophylax the rest of the household. That's quite important. Diphtheria spreads by person-to-person contact. It's usually after close or prolonged contact. The infected person coughs if they've got respiratory diphtheria, sneezes on and there's spread by saliva, secretions from the nose or throat when the child is quite unwell, or fluid from skin sores if they're producing secretions and breaking down, then someone touches them, then the diphtheria can be passed on. As I said, there are some asymptomatic carriers of diphtheria, and they can be an index case that spreads it to the rest of the family. Rarely, diphtheria, Corynebacterium ulcerans, can also affect animals, and rarely you get animal spread from animals to persons. And sometimes, rarely, this animal spread is with close contact with livestock or domestic pets that are colonized with Corynebacterium ulcerans, and also drinking raw milk that can also spread diphtheria. A bit like some forms of mycobacterium could also be spread by drinking raw milk if the cow is infected. But again, this is much less common, more common from person to person spread within a household. Respiratory diphtheria is more common than cutaneous diphtheria, but it's important to know about each of them and to know about the differential diagnosis of cutaneous diphtheria and the differential diagnosis of respiratory diphtheria, because they're different. The treatment historically the treatment was benzylpenicillin, crystalline penicillin, but now there's increasing resistance to penicillin among Corynebacterium diphtheriae, and WHO has recently, just a couple of years ago, put out a recommendation that benzylpenicillin wasn't an ideal drug to use, but we should use a macrolide. Macrolides being like erythromycin, azithromycin, those sorts of drugs. So azithromycin is probably the most commonly used medication now for to treat diphtheria. It's administered orally or intravenously once a day, and there's the doses that WHO are recommending. You can look it up on the WHO website. If you're using erythromycin, again, orally or intravenously every 6 hours, and there's the dose. WHO also recommends diphtheria antitoxin. It's a bit like tetanus immunoglobulin. You need to treat the bacteria, clear the bacteria from the throat or the skin, but also give an antitoxin. We'll talk about the antitoxin in a minute. It's important that the duration of antibiotics is important, and for respiratory diphtheria, you won't clear the bacteria from the throat unless you give 14 days of antibiotics. So the recommendation is for 14 days of antibiotics, both kill the bacteria but also clear colonization, so the person with diphtheria is not likely to infect anyone else. So 14 days of azithromycin or erythromycin is the appropriate treatment for that. If we have a case of diphtheria, we need to give prophylaxis to household context, so 7 days of oral erythromycin, or WHO still says a single dose of benzathine penicillin is okay, but ideally use a macrolide for prophylaxis as well. And then immunize all the household members, because many of them won't be adequately immunized. They may have had their primary course of immunization, but diphtheria antibodies like pertussis antibodies wane over time, so they can diminish over time. So by the time children get to be adolescents or adults, often their antibody levels will be a bit lower. Diphtheria antitoxin is important, very important if you've got a case of diphtheria, because treating the bacteria won't treat the most serious complications such as myocarditis, and won't stop the effect of the protein toxin that's produced by the bacteria. And so diphtheria antitoxin becomes very important. Just like if you've got a case of tetanus immunoglobulin is a very important. Diphtheria antitoxin is a form of immunoglobulin. It's an antibody to the toxin, right? And WHO has a recommendation about the dose that should be used. And the dose is based on the duration of the illness, on the extent of the illness, and the severity of disease. If the illness has been less than 48 hours, and if the illness is only laryngitis or pharyngitis, then a single dose of 20,000 units is prescribed. If there's nasopharyngeal disease with that grey membrane, and that's the only disease the child has, then 40,000 units, so a larger dose. And if the child's got very severe disease with diffuse swelling of the neck, or respiratory distress, or shock, or myocarditis, than giving 80,000 units. So you can see the worse the disease is, the higher the dose of the diphtheria antitoxin should be. If the disease duration has been more than 48 hours, if the child's been unwell for quite some time and had this, symptoms and a grey membrane on the pharynx, then just give 80,000 units as a single dose. And it's important with diphtheria that you give the right dose early and you don't give more than one dose, because diphtheria antitoxin is derived from horse serum. It's a bit like some of the snake antivenoms derived from horse serum from horses that are exposed to diphtheria toxin. They produce an antibody that's then sourced, and the antibody is concentrated and purified, and then that becomes diphtheria antitoxin. But some people have a hypersensitivity reaction to diphtheria antitoxin. It's not very common, and in fact, in the Indonesia outbreak, it didn't occur, but there are some in more recent times. People have taken some precautions when they give diphtheria antitoxin, like the precautions we sometimes take when we're giving snake antivenom, to give some steroids and some antihistamines beforehand, have some adrenaline available. WHO has some recommendations about that. As I said, diphtheria antitoxin is from the serum of horses exposed to diphtheria toxoid. And so as I said, in more recent outbreaks, then antihistamines and corticosteroids, a dose of prednisolone, a milligram per kilogram of prednisolone IV, or dexamethasone or hydrocortisone, whatever you have, prior to 30 minutes to an hour prior to diphtheria antitoxin infusion is a good idea. And you have to, take precautions if you're giving diphtheria antitoxin. Be prepared for hypersensitivity reactions, just like we would be if we're giving a blood transfusion or we're giving snake antivenom. Be prepared for a hypersensitivity reaction. It rarely occurs, but when it does occur, some children need some fluids or some adrenaline, etc., that sort of thing. So have those things ready: oxygen, fluids, adrenaline, blood pressure monitoring, thermometer, corticosteroids, antihistamines. I just want to cover prevention now, and I'm sure you all know this, but immunisation is the best prevention of diphtheria. And I think the reason why it's timely to talk about diphtheria is that immunisation rates are not very good, and probably no more than 40 to 50% of children are properly protected against diphtheria. But the diphtheria vaccine is incorporated into pentavalent. It's diphtheria, pertussis, tetanus, Haemophilus influenzae, meningitis, and hepatitis B. That's pentavalent vaccine, but often we don't consider the D part of it, DTP, but the D is for diphtheria. And so we've been giving diphtheria vaccine for a very long time, but unfortunately the rates are fairly low at the moment. So many people are susceptible. There's been a very recent study of diphtheria immunity, I would say, in East New Britain, and this was done by the IMR team. Professor Laman was involved in this study, and I think it's an interesting study. It's only published last month and very timely given the rise in diphtheria in many countries. And they looked at 285 children in East New Britain, and three-quarters of those children had 3 doses of pentavalent. So you'd think that they would be protected, but only 16% had antibody levels that were high enough for full protection against diphtheria. And it's not really clear why that was. And I suspect that the protection against diphtheria is not an all or none phenomenon. You're not either protected or not protected. You're either fully protected or you're partly protected. And I suspect that the majority of those other children who are vaccinated were partly protected. But I think it just tells you that we need to keep immunisation rates high to have as many children fully protected as possible. In this population, 46% were protected against tetanus. And so you'll see perhaps that even though 75% had their adequate doses, not all those people who were immunised were protected. And that may relate to, again, what I said about waning immunity over time. It might relate to issues of poor nutrition, and children who are malnourished don't mount as good an immune response. It might relate to how early immunisations are given, and maybe that is causing a delayed or suboptimal immune response. But either way, there's a high proportion of people susceptible within the population to diphtheria, and that's why we need to be alert for it. Just like for all vaccine-preventable diseases, this is a notifiable vaccine-preventable disease. So that's all I really want to say, but just to summarise what we need to know about diphtheria. It's a toxin-mediated vaccine-preventable disease. We need to know about the microbiology and how important it is to get throat swabs or skin swabs and look for gram-positive rods on gram stain. To understand the clinical presentation, there are, to understand that it mostly causes respiratory disease, but it can look like croup or tonsillitis or laryngitis or peritonsillar abscess or mumps, epiglottitis. It can look like all those diseases, but the key is the grey membrane. And cutaneous skin diphtheria can look a bit like yours, or Buruli ulcer, or Mycobacterium marinum, or staph infection of the skin. It can look like all those things. And so we need to be aware that some children that we see might have diphtheria, and just think about it. And we need to know about the treatment. The treatment is multifaceted. First of all, antibiotics to clear the bacteria. Remember, using a macrolide instead of benzylpenicillin mostly, if you've got that. The antitoxin and how to give that. One dose, not multiple doses. Beware, the hypersensitivity reaction is much more likely if you give multiple doses. That's why WHO recommends you give the right dose first. And then supportive care, which we haven't touched on too much, but clearly these children, need very good supportive care, and they should be managed just like any child with upper airway obstruction in an ICU setting that can provide respiratory support if needed, can provide airway protection and airway support. And then prevention with immunisation, and why it's doubly important now to increase immunisation rates. That's all I want to say about diphtheria. I thought we should talk about it because we haven't, covered it too much, and it's it's an emerging disease, and it's important, I think, especially to know the differential diagnosis of it. So when we see children with such symptoms, we're not making a diagnosis of diphtheria, but we are considering it in the diagnosis, and we know how to rule it in or rule it out. That's all I want to say today. So I'm going to stop the recording now, and I'm happy to answer any questions that you might have. All right. Thanks, everyone.